Next, I would like to introduce our next speaker, Mandy David. She's the Senior Public Health Analyst and Team Lead within the Genetic Blood Disorders Branch of the Health Resources and Services Administration, also known as HRSA. Thank you so much, Mandy, for joining us, and I'll turn it over to you.
Thank you. Good morning, good afternoon, everyone. Thank you for having me. We can go to the first slide. So I will be just giving a quick kind of factual update and maybe touch briefly on some of the things that Dr. Houlihan said with regards to us looking at data in different ways and in improved ways now. But yeah, I'm about 2 years at HRSA, really happy to be here. And before this, worked as a adult provider, as a physician assistant, taking care of adults with sickle cell disease for over 20 years. So very happy to be here. Thank you. You can go to the next slide. So I will move through this slide pretty quickly. I just like to talk about a little bit of history of how HRSA is even involved in kind of access to care model and the work that we do, which is the bread and butter is access to care. But how did we get here? We all know that in the 70s that there was a National Sickle Cell Disease Control Act. That brought about a lot of sickle cell activities and changes in legislation and funding mechanisms. But it wasn't until kind of like 2014, 2017 that we had this regional model where we said we could kind of give money to different regions that are spread across the US. Can't give money to everybody, but we can give money to some regions that are doing specific comprehensive sickle cell disease-based work. In 2017 to 21, all regions were funded. When I say the entire US, it wasn't that we were funding every state, but we were cover every comprehensive center in each region, and there were 5 of them. You'll see that in a slide I'll present in a moment, were funded. And so that was a bigger deal. Not only do we have regional infrastructure, but now we have funds that go to those different regions as well, based on the amount of sickle cell patients they have in that region. And then we're currently in this cycle. I started in 2021 and spearheading this version of our demonstration program. And now all our regions are funded. And the newest and maybe arguably extremely valuable, most valuable part here is that we are directly funding community-based organizations. And I know many of you here represent them. It's been a long time, I think, until we had like a unified voice of community-based organizations, especially on a federal platform. And so we fund 25 organizations. Obviously, there's way more sickle cell disease-based CBOs, but we now have a snapshot that we are directly giving federal funds to, not through a liaison, not through a contractor, not through a partner, but directly giving funds to these organizations in order to continue their work and also provide us data so that we know that we are making, that we are being effective when we are giving funds to these regions. We've served over 25,000 people. That number is adjusted a bit. I will talk about that in a moment, but nonetheless, we are in our 5th cycle of our demonstration program, and we continue to train physicians, APPs, community health workers, nurses, etc. Next slide, please. So, oh yes. Thank you, Hertz Nazir. He's a painter, and may he rest in peace. I could not ignore that message. He's one of my favorite people. And thank you for calling that out. So we have the TDPs. Those are our sickle cell disease treatment demonstration program. I'll get into more of this in the slide because I want us to all be really clear in how HRSA operates. And I think until I got into HRSA, I too was like, well, how does this work? How are we funding different regions? Who's involved? And so now I'm going to make it very clear. We have the demonstration program. Those are 5 regional grantees. Those are our 5 comprehensive centers. That project period is 5 years. It started in 2021. It ends in 2026. So then you'll see that we'll have the new project period starting in 2026. Now, the newest component of our program is the community-based organizations. There are 25 of them. There were 20 that we awarded. We got extra funding to supplement, and we gave it to 5 other community-based organizations, all kind of in proximity to the regions of the comprehensive centers, the TDPs. So when I say TDPs, I'm usually talking about a clinically comprehensive sickle cell center. We're funding 5. When I say FPs, or sometimes I'll just go ahead and say community-based organizations, that's what I mean, that these FPs are the Sickle Cell Disease Newborn Screening Follow-up Program, and they are community-based organizations. We all have started in September 2021. Now, the APT associates, they are our TA center. So hemoglobinopathies, people are like, why didn't they call it sickle cell? Well, it's called hemoglobinopathies, but nonetheless, they are the TA center that facilitates all the work being done between the CBOs as well as the comprehensive sickle cell centers, the TDPs. Their period of performance is also 5 years. All right, next slide. Okay, I've added this slide because I think it's important that we do know that this is not just one, it's one big program coalesced from different funding mechanisms, okay? So we have our HRSA sickle cell disease program. I manage that with a great team, and under that umbrella are the demonstration program. That is a cooperative agreement, which means we work with them. There's a lot of decisions that we work with them. These are just funding mechanisms. Don't always have a choice in those, but nonetheless, this is what it is. And so you can see that came out of the Public Health Service Act, and that's how that is funded. I'm going to go to the other side of this diagram, which are the community-based organizations, and that is a grant. And so that is funded under SPRANs, Special Projects of Regional and National Significance. Separate funding mechanism separate funding mechanism that goes directly to fund the community-based organizations, very different than the TDPs. And then in the middle is our TA Center, which is a contractual vehicle. That is a contract to oversee the work being done by the TDPs and the FPs that they manage. And so we have to they're all managed very differently. As you can see, cooperative agreement, contract, and grant. Those are three different funding mechanisms, three different managements, but nonetheless, they are all under the same umbrella of the work that we are doing to improve the lives of those living with sickle cell disease. So when we talk about funding and how it's moved, or where, this contract or this vehicle, please understand that there is very much a difference, not in the work that we're doing, but in how the money is distributed and how the work is managed. Next slide, please. This is quickly here, our regions. I'll show you a map that will better illustrate it in a moment. But nonetheless, when it comes to sickle cell, because not every genetic disorder has 5 regions, some have more. But in sickle cell, there are 5 regions: Northeast, Midwest, Pacific, Heartland, Southwest, and Southeast. And as you can see, when we talked about those 5 comprehensive sickle cell centers, the top ones are the demonstration programs where they're housed. Hopkins, Children's Cincinnati, CIBD, the Comprehensive Care and Diagnosis for Inherited Blood Disorders in California, Wash St. Louis, and University of Alabama. So those are our 5 TDPs. And then associated with them underneath are just our regional 4 to 6 community-based organizations in that region. So you can take a look. A lot of you all are in the audience. Hello. I love working with the CBOs. I love working with the TDPs and looking at best practices and ways that we can kind of merge together. And there's some CBOs that are working with the TDPs that are not awarded through this HRSA grant. So I don't want this to just be a snapshot of all that's happening in the country. There's so many things happening, but nonetheless, this is who we fund and per region. Next slide. This is the illustration I think is very clear here. As you can see, the 5 regions are kind of color coded. Don't mind the names. Those are just kind of names for those regions that have been named, and they all stand for something in relation to sickle cell disease and the work that they are doing. So we see the 5 regions. And as I said before, not every state is covered. And sometimes it's just a clinical site in a state. It's not, the entire state. So you can see the green stars. The green stars represent our demonstration programs. Our comprehensive centers are located at those green stars. Now, what we talked about already is our newborn screening follow-up program, our community-based organizations, they are and how they in our proximity to those demonstration programs. You can see that in this illustration here. And don't mind that 6, that's a typo there in the PSCRC area. The other piece I wanted to add on is that the purple dots represent clinical sites. So each TDP region, as I've stated before, has about 4 to 6 community-based organizations in their region, whether they knew them before this work or not, they're in that region. And then they have 7 to about 16 clinical sites. And that relationship between the comprehensive center and clinical sites is typically data. We know how many patients that particular clinical site is serving. We may not have all the information in that state, and that's why we're talking about how do we connect with CDC and the work that they're doing in those states. But nonetheless, that is the relationship that we have with regards to how this program spreads through clinical sites, through our community-based organizations, all typically through our hub, as we like to call them, of our comprehensive sickle cell TDP program. Next slide. So when we look at data, in year 2, across all regions for our demonstration program, we served approximately 22 individuals living with CDC. Now, we did some tweaks to our, not even tweaks, we kind of up our data collection, our methodology to really get really good data. We really want a good number. We have good data, but the data, there's always room to improve, and making sure we're collecting the same and we have the same methodologies and everybody's moving in unison with how we're defining certain things. And so we know that we are, that 22,000 was a good number. Year 3, which to date, we now, and this number is kind of hot off the press here, is 25,000. So the goal is that we continue to, and that is using the same methodologies as well. And so we know that we're getting uniform data and that we're kind of looking at it from year to year to year. We'll have more of a bigger picture at the end of the period of performance, but nonetheless, we know that we are moving in the right direction and increasing the amount of patients served through the funding of HRSA for access to care. Now with FPs, this is new. This is new for everybody involved. This is the first time a lot of them are getting federal grants. This is the first time we're having data conversations. So in year 2, the FPs, or the community-based organizations, reported that they're serving 8,000 individuals living with sickle cell disease. In year 3, we're still looking at those numbers. I want to be transparent in saying that the data collection and making sure it's uniform to tell our story, the accurate story of what's happening with sickle cell disease, not just from a clinical perspective, but from a social determinants of health perspective, is very important. And so we want to make sure that when we say served means this across the board for CBOs. When we say that this family was served, we mean family, or do we need the actual patient? We have to clarify that. So we are looking through that data to make sure that that in the event that we are able to publish it, that it is very clear. We also have the data advisory committee through the FPs that are helping translate that information so that we are all speaking the same language when data is collected and reported. Next slide, and I think we can move a little faster because I know we have a minute. I will not go into all the details here, but this is how we look at the work at HRSA, that there is a system of care that does not include just clinical services, and that we are all reaching for the same goal, children and adults, not just living, not just surviving, but thriving. And so that is very important. And so we do a lot of activities around all of these points on this system of care. Next. We continue to train community health workers on the specifics of sickle cell disease. We have QI programs. We are working closely, as you've heard from Dr. Wong and Dr. Houlihan, and working very closely with our sickle cell agenda on a federal platform, which we talk about in our annual meeting in June. And so this is a constant it's a constant work from the NASEM report to today, and conversations around sickle cell are just rich. And so it is nice to have a lot of the in-depth conversations that we're having outside of the federal offices as we are inside now. Next slide. And I've talked about this. You can go forward and on the next slide as well. Yeah, so the next steps, we'll continue to work with CDC for our data collection. I think I saw some questions about what does it look like. I think Mary hinted that, there's surveillance data. CDC can tell us where patients are. And then maybe TDPs and our work can come in and say, well, this is what we can offer, and this is what CBOs can do. All of this is the things that we're discussing, but we know that we don't want to be duplicative. We know we don't want to just collect data to data. We want to tell the story of the work that everyone on this call and outside of this call are doing. And so it's important that the data reflect that. And so we'll continue to work on QI. We have a lot of discussions, interagency discussions on sickle cell disease, and the community health worker, which I take pride in. The community health worker training is very important for how we move forward in this work and the role that workforce plays in sickle cell disease. Next slide. This is a team that my team that I work with very closely on all of the CBO and TDP work. So I want to say thank you for your attention today. I know we didn't have a lot of time, but I am always open to take emails and talk to anyone who's willing to listen and collaborate. So thank you very much for your attention, and thank you to Sickle, and thank you to the sickle cell patients living with sickle cell who hold us accountable for all the work that we must do. Thank you.
Thank you so much, Mandy. That was such an informative presentation. I truly enjoyed it, and I believe we have one question from the audience. So is there any way, how do we determine whether we have served the family or the patient with using and looking at this data?
Yeah, those are some of the things that we're teasing out. I think we've historically reported on if the family's being served, then the patient is being served. But we have to separate that out. We really want to know how many families we are serving, and separately, how many individuals we are serving. So those are the things that we're looking at now. Historically, we have not separated that out. And so we don't want our data to look conflated that we're serving more people than we are, because we want to show the gaps and so that we can appropriately fill those gaps. So it's a big question, but it is something that we are working on very closely now with our data advisory committee. We have taken a cohort of FPs who are helping us clean that definition, because it's not about who and what, it's about how do we define it so we're reporting it the same, so this narrative makes sense and is accurate to what we're doing in the field.
Awesome.
Thank you for that
Thank you
question.
so much.
Thank you.